Thank you all, and welcome to today's webinar, Medical Aid in Dying and ALS, How the Option Can Ease End-of-Life Suffering for Patients with ALS. I'm Dr. Rebecca Thoman, and I'm the director of the Doctors for Dignity Initiative of Compassion and Choices, and I'll be your MC this evening, guiding you through this webinar. A quick reminder that the webinar is being recorded, and it will be posted on our website for people who may not have a chance to see it or want to see it again, and that should be up in the next day or two, so check out our website for that. Also a reminder, the chat is off and you are neither visible nor can you be heard, so we're asking you to submit your questions through the Ask a Question and answer box. And if you would like, you type your question in right where it says type your question here. And if you'd prefer to be anonymous, you can check the anonymous box and then your name will not be associated with the question. So many of you know who we are. Compassion and Choices is the nation's largest and oldest nonprofit whose mission is to improve care, expand options, and empower everyone to chart their end-of-life journey. Doctors for Dignity is an initiative of Compassion and Choices, and you can read more about us at compassionandchoices.org/D, the number 4, capital D. We're a community of physicians, and from across the country, I think we have people from 48 out of 50 states. We advocate for a full range of end-of-life options, including medical aid in dying. We work to reduce end-of-life disparities, and our goal is to bring the voice of medicine to public policy. I'm delighted to introduce today's speakers. Dr. David Grube is the National Medical Director of Compassion and Choices. He's a retired family physician who practiced in a small town in Oregon for many years, and he saw the first implementation of Oregon's Death with Dignity law and was there through the entire process and has a lot of experience writing prescriptions for patients. Lenore Keibel is from Minneapolis, Minnesota, and Lenore is going to share her personal story. Her beloved husband, Brian, experienced ALS and did not have the option of medical aid in dying, and she'll share a little bit with you about her thoughts about this and the need for this access for folks with ALS. And then Ryan Spielvogel is a family physician from Sacramento, California. He's been heavily involved in training doctors and residents in medical aid in dying and also has experience with providing prescriptions for medical aid in dying and working with patients who have neurological disabilities. So what we're going to cover this evening is we're going to talk a little bit about ALS. What is ALS? How does the disease progress? We'll get everybody on the same page about what is medical aid in dying. How does it work? What are the components of medical aid in dying? We'll talk a little bit about the communication challenges that uniquely face people with neuromuscular disorders. We'll talk to you about the medical aid in dying medication protocols. And we'll talk a little bit about the definition of self-administer, because that's a very critical component to medical aid in dying. And then we'll talk more specifically about the use of medical aid in dying in neurodegenerative diseases, things like the routes of administration, how do you time use of the medication, and what's the role of the family or other support systems. And then at the end, I will give you a few resources that you can take away with. So we'll have a significant amount of time for Q&A at the end, and then I'll give you some resources that you can go to for further information. So right now, I'd like to introduce Lenore and thank Lenore very much for being willing to come on and share your personal story about Brian's experience.
Mm-hmm. Good evening, thank you. Oh, excuse me. Well, in June of 2016, my very physically active husband, Brian, was diagnosed with ALS. Brian had been a physical trainer. He'd worked in maintenance and security. He loved building things. He loved kayaking. Everything changed very quickly. Except for his speech, he lost his entire physical being over a period of less than 2 years. He had started having difficulty with his left leg early in 2016. One night he fell up steps, which for a very graceful and physical person like himself was unheard of. He went to the doctor with the leg. It persistently wasn't getting better. About the time that he noticed that he could not raise up the toes on his left foot, that was when we really progressed forward to an actual diagnosis. We were lucky to be in a place like Minneapolis where that could happen quickly. We have some good specialists here. We were told, however, that the average life expectancy was 2 to 5 years. Brian, from the beginning, wanted the option of medical aid in dying. He'd been a very adamant advocate for it long before his illness, and was especially after getting sick. Living in Minnesota, however, this wasn't an option for us in our home state. He had seriously considered going to another country to access that ability there. Brian was serious enough that we both got passports. It was the first time in my life that I felt very clear that a person who chose this for themselves at the end of life had a right to do this, as long as they had mental clarity and a terminal diagnosis. I told Brian, you know, whatever you want. If you want to go to the very end with this and extend your life as long as possible, I'll help you do that. If you want medical aid in dying in another country, whatever, I'll help you do that. Brian, however, in the end, he hated traveling, always had, only liked to go to northern Minnesota pretty much. As his disease progressed, it just didn't make sense for us to go to another country with people that, you know, didn't even speak our language, and he wanted to die at home. And we started cementing plans for his end of life about a year and a half after his diagnosis, right about the time that he started to progress quickly. And the option that he talked about was to voluntarily stop eating and drinking, V said. Brian was soon enrolled in hospice because they you know, do provide numerous benefits really for patients. And at the end of 2019, in February of that year, he made a clear decision that he had passed his line in the sand. He was starting to have real difficulty with his breathing, I think, which was his line in the sand, and that he was ready to utilize, he said. His doctor, his own doctor at hospice, was very agreeable to that. The hospice nurse was, you know, great with it. We were promised that everything possible would be done for him to ease this VSED process for him and ease him through the end of life. It started really calmly. He had been asleep for nearly 24 hours though, and he woke up screaming and yelling, and he was in terminal agitation. With the support of his attending physician, we got him medication to calm him again. But within 36 hours, Brian was once again extremely agitated and uncomfortable. His doctor was not available, and it was severe enough where we had a house visit from another one of the hospice doctors. He immediately questioned Brian's decision to utilize VSED, and he said, so he stopped eating and drinking and he can still swallow. I explained Brian's decision to him. And I said, given what his mental state has been, I want him sedated from here on in. And he responded, it's not about what you want, it's about what Brian wants. That, I must say, was a pretty hard pill to swallow, you know, having been pretty much an instrument of whatever Brian's will was on this for a year and a half. almost 3 years, excuse me. And I responded pretty sternly. What he wanted was a way to end it now. What he wanted last night was for me to give him all the morphine. He'd been furious at me that I could not do that. And I said, now you need to follow through on what the plan is and keep him comfortable. What is the possible benefit for him right now in being awake? And he backed off. The hospice nurse was there. That did help. And we were able to get him some appropriate medication. 6 days later, on March 13th, 2019, after 6 days, V said, Brian died after deciding to, after making his decision. And when he could, as I said, he could no longer breathe well on his own. He was paralyzed at that point from the neck down. He was 66 when he was diagnosed. He died a few months before his 69th birthday. My husband would have much, much rather had the choice of medical aid in dying, and he talked about how he would have much rather had that choice frequently. And years before we knew that any of this was going to happen, we had actually gotten into an argument about medical aid in dying. I wanted him to stop talking about it, and he was bent on talking about it that day, 5 years before he was diagnosed. He was such a strong advocate for it. With, my Catholic religious background, etc., I was very on the fence about it. I didn't understand. I didn't want to talk about it. I didn't become a full supporter until my firsthand experience with Brian. And, obvious, as we know, ALS is invariably fatal. Brian could barely breathe when he asked why he didn't have the same choices that some other people in this country and other states had, Oregon, California. He shouldn't have had to go through all that he did. He should have had the free agency. And I think that the choice of medical aid in dying would have brought him a great deal of peace, not only at the very end, but just knowing that he had that available to him would have meant a great deal to Brian. And I'm sorry he didn't have it. And I guess with that, I will pass that back to
Thanks, Lenore.
Thank you.
I know there are a lot of people out there watching this webinar who have loved ones who are currently dealing with ALS or another neurologic disorder, or may have lost a loved one. And so thank you for setting the stage for why this is so important. So thanks.
Thank you.
Okay, now I would like to hand it over to Dr. Spielvogel.
Hello, and thank you also, Lenore, for sharing that powerful story about Brian. So I'm going to start by talking a little bit about what ALS is. So ALS stands for amyotrophic lateral sclerosis. Another name for it is Lou Gehrig's disease. You might have heard of it referred to as that, named, when it's talked about that way, it's after a famous baseball player named Lou Gehrig who had ALS. And the tricky part about ALS is it's highly variable how it presents. So it's really a combination of several kinds of disorders all in one. And where it gets its name is that it affects both nerves in the brain and spinal cord, what we call upper motor neurons, as well as the neurons that travel from the spinal cord down directly to the muscle, known as lower motor neurons. And people can have different kinds of symptoms depending on which neurons are, which nerves are most affected early on compared to later. So people tend to get very stiff with ALS. That's a function of more the brain and spinal column nerves being affected. And they can also get weak. In most cases of ALS, weakness frequently one side more than the other tends to be the very first symptom. So someone who's normally very strong, they're noticing that that their left hand has become weak and it's not getting better and they don't know why, where they start having difficulty walking because one side is weak when the other side isn't. Some people can also get weakness in the muscles of their throat or in the muscles of their tongue. And so they can have garbled speech or they can have difficulty swallowing. In most people, that's a later finding, but in some people, that's the first finding. So it can be highly variable in how it presents first and then how it progresses later. And so this picture here, you can see that the disease has to do with how a healthy nerve on the left side, that is those little things that almost look like jelly beans around the nerve cell, help with the conduction of the nerve signal down to the muscle. And then the nerve has strong connections with the muscle. And that in this disease, what you get is a nerve that looks a little bit more like the nerve on the right, where the conduction of signal is interrupted. And then as a result, you get muscle loss and weakness. You can go to the next slide. So ALS progression is highly variable because where it affects your brain and spinal cord and muscles first, and how quickly it changes, really dramatically changes depending on the case. So early stages, people tend to notice some muscle weakness, cramping, spasticity, which means that they can get kind of jerking motions. Tends to be more onset in the limbs, arms and legs, rather than the trunk and ability to hold yourself up. As it progresses, people get more profound muscle weakness, some muscles becoming paralyzed. Dysphagia means difficulty swallowing. Dyspnea means difficulty breathing. Dysphonia means difficulty talking. And then it can also affect the brain and different parts of the brain, which can lead to other kinds of effects, such as changes in personality and mood sometimes. And in a late stage, people can be paralyzed, and not just their voluntary muscles, but also paralysis of the diaphragm, which can lead to respiratory arrest and need to be on a ventilator. And it's worth noting that this can go very, very fast in some people, a matter of months, and in other people take many, many years to progress. And I'll hand it over to Dr. Grube.
Thank you, Dr. Spielvogel. And again, as you mentioned, and I'll mention as well, my sympathy to Lenore and Brian's family. And thanks to her for sharing such a personal thing and such a real thing, as I know many people who are listening to this are affected by this and other degenerative neuromuscular diseases. Well, we're going to talk a little bit now about what is medical aid in dying and its availability and access. And as Lenore mentioned, it is not available in every place. And I practiced in Oregon, and Dr. Spielvogel practices in California. And in both of these states, medical aid in dying is an option. This slide shows what other options individuals have. And of course, the majority of individuals pursue all life-sustaining treatments. That's the default in American medicine, to do everything. And that's a choice for many people, and that's the right choice if that's what they want. However, we do know that individuals can stop treatment or refuse certain kinds of treatment after they've been given informed consent. They have that right to do that, and we can't force people to have different types of treatments. It's so important, and we'll be talking several times this evening about the value of hospice and palliative care. And I must say, in diseases such as ALS, hospice is invaluable. And if you or your loved ones are not connected to hospice, that would be so important to do. And I'll give a couple case examples of that later on. But hospice is so important in these degenerative and diseases that cause inevitable decline. Lenore spoke about the choice that Brian had of voluntarily stopping eating and drinking. And as you heard, it's a difficult process that takes quite a while, at least a week, and is fraught with situations that she and her family got into, such as agitation and suffering. And so it is an alternative in every state. It is legal in every state, but it takes a lot of work, a lot of teamwork, and many people are unsuccessful in their efforts to have their this choice or option. Sedation to unconsciousness, or also historically known as terminal or palliative sedation, is a high-tech, usually institutional option that's not available to everyone, but is still an option. And then finally, tonight we're going to be talking about medical aid in dying. So what is medical aid in dying? Before I get to that, I want to dedicate my portion of this webinar to a dear friend of mine, Dr. Richard Olney. I knew Rick since residency and when he was in private practice here in Oregon as a neurologist. But he moved in the early 1990s to San Francisco, where he joined the faculty at the University of California, San Francisco, and became the director of the ALS Center there. He was a pioneer in ALS research and care, and he was a very compassionate physician. He began to have symptoms of some kind of a problem in about 2014 and was subsequently diagnosed with ALS. Such an irony that one of the world's most famous ALS doctors would catch this disease. His trajectory was a little slower than Brian's. It was about over 8 years, but with the loving help of his wife, Paula, and children, Amy and Nick, he had a great 8 years and an excellent, each day he lived to the fullest. So I put on here, and you'll be able to go to a website to read about Rick. And I miss Rick, and I want to dedicate this to him. Next slide, please. Medical aid in dying authorizes that a terminally ill, that means someone who has less than 6 months to live, adult who is a resident of the state in which they're going to use this process, may request from their physician a medication that they will self-ingest to peacefully end their intolerable suffering and cause their death. Next slide. It is not a simple process, and many of these safeguards that states have also become barriers. It requires 2 verbal requests, generally separated by some period of time, in most locales 2 weeks, from a doctor about the reason the patient would like to have this, and then they also have to write out a written request that has to be signed by 2 other individuals. There's also a second physician that needs to be involved. That is called the consulting physician. And so these are 4 interventions, 2 oral requests with the attending physician, a request from a consulting physician, and the written request, all of which takes some time. There has to be no evidence of coercion. The individual must have capacity. That means they must be able to understand informed consent. And if there is a question about active mental illness that is impacting their decision-making process, it's appropriate for either of the 2 doctors to refer to another doctor for a mental health evaluation. All of the end-of-life options that we've previously mentioned need to be discussed. Hospice should be offered, and other caveats about not using the medication in a public place or being alone at the time of ingestion, etc. And then all of this is documented in the medical record and usually on some state forms. Next slide, please. So currently there are 10 states, which you see here in the blue, where medical aid in dying is authorized, and the District of Columbia. Many other states, including Minnesota, where Lenore lives, are considering statutes and laws that would authorize medical aid in dying. About 1 in 5 US citizens now have this option. So if you live in a state where it's an option for you or your loved ones or family, that is important information to know. But if you don't, it's very, very important, because particularly if you're a healthcare provider, there'll be many questions that will be asked as the reasons for our death become ever more complicated. Next slide, please. A number of organizations have a neutral position in regard to medical aid in dying, including Dr. Spielvogel and my American Academy of Family Physicians, who moved to a new position of neutrality in 2018, the American Academy of Neurology, and the American Academy of Hospice and Palliative Medicine. Next slide. So what are the diagnoses that individuals have who consider this end-of-life option? By far and away, the vast majority, almost 3/4 in every state, is cancer. And essentially this is cancer that has been treated and treatments are no longer successful, and the individual is having intolerable terminal suffering and are near death. But as you can see, there are others, and the second biggest wedge of the pie is that black triangle at about 9 o'clock, which is what we're talking about tonight, the neurological diseases, in particular ALS. Next slide, please. This is what I mentioned earlier, the safeguards, which indeed on occasion become barriers, which vary from state to state, but in general, they are these. And it is important to note, particularly for ALS patients, that telemedicine is legal, with the exception of the state of Vermont. That means that the individual who has ALS and may be bedfast does not need to go to the doctor's office, but using one of the new modalities of telehealth, the requests can be done over the phone. Next slide, please. So now I'm going to return it back to Dr. Spielvogel, and we'll be talking about some of the challenges that are unique to ALS, in particular, the individual's ability to speak as the disease progresses.
Right, and so we have on here a picture of Stephen Hawking, who technically didn't have ALS, he had motor neuron disease, but it's a very similar and related condition, neurodegenerative condition. So as ALS progresses, we know that patients can develop difficulty speaking, difficulty communicating. How does one give a verbal request if they have lost the ability to speak? So now the laws do specifically refer to verbal requests, but we know that many ALS patients have developed other, if they can't speak and verbalize their wishes, they have developed other forms of communication that might be nonverbal. They might use speech pads, like you see Stephen Hawking doing here, that bases eye movements to basically spell out what they wish. I have had patients who communicated mostly through series of blinking, a series of blinks. So there are other ways to communicate, but I think the real point to make here is that once somebody is to that point, they might, for ALS, be possibly too far gone to access this option. And so much of this is planning, having conversations with your physician ahead of time, having conversations with your family ahead of time if you have ALS, And this is potentially a wish of yours or desire of yours, so that you're seeing your physician and having that conversation with them upstream of getting to this point where you're having difficulty communicating or swallowing. And we'll get to routes of and how people actually take the medication in a bit, and how that can change with people with ALS. But it obviously does get more difficult as someone becomes progressively debilitated. You can go to the next slide. Okay, so wanted to spend a little bit of time talking about the regimen itself as is currently used. And it is important to state that this is one of the current formulations. And in fact, the newest version has an additional medication in there that's not on this slide. And this regimen and the current form with phenobarbital has been developed over many years with a vast collaborative network of physicians led by Carol Parrott and Lonnie Shavelson and the American Academy, or the American Clinicians Academy of Medical Aid in Dying, and a huge network of providers kind of looking at our regimens and making it better and better over time, so that we've really gotten this down to a science. So I just wanted to throw a shout out there to all the clinicians who have contributed to making the regimen what it is today. So this is kind of in general how it goes. Somebody is NPO, meaning that they have nothing to eat or drink other than some water for 4 to 6 hours before ingestion on the day of ingestion. Otherwise, they're able to take their usual medications that might help with their suffering. And then 1 hour prior to the ingestion of the final medications, they take a couple of heavy-duty anti-nausea and vomiting medications, and this is primarily to prevent them from vomiting up the active ingredients, because that's what everybody is always concerned about, is that they don't want, the doctors don't want the patients to throw up the active ingredients, and the patients don't want to throw them up either. 30 minutes later, they take the first active bottle, and this is a medication called Digoxin, which is a heart medication, and this will act to slow down the heart. And we give it first before the rest of the medication, so that your body gets time to absorb the relatively small dosage of Digoxin compared to the other active ingredients, where the Digoxin might get lost in the mixture. And then 30 minutes after the Digoxin, they take the second and final bottle. And I usually warn patients to make sure that they have said their goodbyes and said everything that they want to say to their family or friends who might be present before they take that last bottle. It has a very strong mixture of a sedative, diazepam, otherwise known as Valium, and morphine, and another medication that acts on the heart called amitriptyline. And generally people drink this and then they go to sleep within a couple of minutes. Everyone's asleep by 10 minutes, but usually people are asleep before then. So it's important to say goodbye before then. People drift into a deep sleep, and then most people will quietly and peacefully pass within the first hour after they take it. It might go as long as 2 or 3 hours. It almost never goes past 4 hours, where someone is peacefully asleep the entire time and then they just peacefully drift off. It is also important to note that this is one version of the regimen. The newest version, thank you, the newest version includes phenobarbital in that final mixture, which is another heavy sedative. Other regimens might lump the Digoxin in with the diazepam, morphine, amitriptyline, and phenobarbital. Some locales have kind of done slightly different dosages of things, or done other pre-medications to help prepare the body for receiving these medications and then doing what they're going to do. So in practice, the regimen that is used might vary slightly from place to place, but again, thanks to this massive collaboration among physicians and ACA MAID, and we've come to a pretty specific regimen that doesn't vary too much. Okay, we'll move to the next slide. So liquid versus powder. So it's all compounded together, which means that you can't get this from a regular pharmacy, and the doctor who is prescribing your aid in dying drugs will be getting it from a compounding pharmacy, and one that knows what they're doing. And they basically will give these to you in a couple of different bottles. The Digoxin usually comes in a larger plastic bottle and then the DMA or DMAPH will come in a glass bottle because the diazepam absorbs into plastic, so it has to be in a glass bottle. Depending on the specific situation, it might be dispensed already as a liquid. Most of the time it is dispensed as a powder, and then there's instructions along with it for how to reconstitute it into a liquid. It's actually fairly simple. You fill the bottle up with 4 ounces of water or clear juice, shake it really well, and then drink it. And yes, so contrary to common belief, it is not a pill that people are prescribed. It's actually a drink, or it's dispensed as a powder and then you make it into a drink. We can go to the next slide. And I'll hand it back over to Dr. Grube.
Thank you, Dr. Spielvogel. So this is the whole thing that Dr. Spielvogel was speaking about earlier, the complications of ALS. ALS is inevitably fatal. And there is a constant decline, and the slope of the decline is variable, not only the steepness of the slope, but sometimes there are steps in it, and there may be a time where there's not quite as rapid degeneration, and then other times when there's a rapid degeneration. So timing in ALS, if a person is considering this end-of-life option, timing, as Dr. Spielvogel said, is everything, and planning is everything. So that's it's important for everyone to be educated about this option and to talk about it. And sometimes that's very, very hard to do. But because ALS is always fatal, we can, unfortunately, as a doctor and nurse or other people say, that this will cause the individual to die. And so we can say, what would they like? Can we provide that very last day to be the best that we can? What do they want? What are their wishes for their last day? Who would they want to be in the hospital? They want to be home? How can we make that happen? Do they want to have their family with them, or maybe there are other individuals that they would like to have with them or not with them, their pets, music, their candles. All of these things can make the death experience better, and we should talk about that with the family. As we talk about that and ask them these questions, such as who would you like to be there, where would you like to be, we can also say, would you like to determine the date of your death? It's just a part of the palliative palette that is an easy way to let them decide if that's a choice that they want, and if they do, how to help them learn about it. Because it's sometimes very, very difficult to present this option to the loved ones and the family. And that's a way to be able to do that. So planning and timing are so important as the individual declines as each day goes on. Next slide. So it's really important, I think, to talk about administration. Administration means that the individual who is taking in this medication chooses to do that in an affirmative way, that they have volition, that they have knowledge of what they're doing, and that they don't have to do this. They have the right to rescind their choice at any moment. That's the important concept of administration. Ingestion is the taking in of this into the alimentary canal or into the a place that it will be absorbed in your body. So anything that is taken by the mouth, but also in other ways through a feeding tube. Dr. Spielvogel will talk about this in a minute. But that's ingestion, and that is what medical aid in dying is. Injection is using a hypodermic needle or a syringe, and this is not a part of medical aid in dying, where someone takes a serum or something and it's injected into their body. Now, assistance is what we, who are the loved ones or the medical team about the patient, we can help them and assist them. We can mix the medication, we can hold the medication, we can hand the medication, we can pick up the medication. All of these things are assisting, and that is legal. So administration only by the patient, and assistance can be done by anyone. Next slide. Dr. Spielvogel.
Yes, so ingestion, as Dr. Grube was just pointing out, is a common word used in the laws, and ingestion does mean using the absorbed through the GI tract, but it doesn't say where in the GI tract. So that at least we can work with. So most commonly, these medications are taken by mouth, meaning somebody swallowing the medications, but it can be used, it can be given through NG tube, which is a nasogastric tube. You see that picture on the top left with a tube that's placed into the stomach, and then the meds can be pushed through there if someone cannot swallow effectively. Similarly, if someone has a PEG tube, or which otherwise known as a G tube, which you see on the top right, where they're typically getting their nutrition or other medications pushed through, that is fairly easy to hook this, to draw up this medication all into a syringe and push it through that into the stomach through a G tube. And we have also done this via rectal administration. It does work that way as well. So in the bottom middle, what you see is basically a special catheter that is placed into the rectum, a balloon inflated so that it stays in place, and then medications can be pushed through that. Doesn't sound the most pleasant, but it does get the job done when someone needs that. And by the way, I did also just want to answer a couple of the questions that I saw in the Q&A, if I may. Somebody asked about a pacemaker. Pacemakers are not an issue for this because if someone goes into a fatal arrhythmia, which is what the amitriptyline digoxin combo does, pacemaker doesn't stop that. Cost of the medications, people do generally have to pay for this out of pocket. The price varies from between around $350 to $650, depending on the pharmacy. We talked about speech and verbal communication, but what about the written request? People who are unable to write or sign their signature are able to do like a thumbprint or an X on a paper, and that is sufficient. And then the amitriptyline, I didn't mention, somebody put in there that it does burn on the way down. Generally, that burning is assisted afterwards by having a little bit of honey or non-dairy ice cream like sorbet after the amitriptyline. The burning generally does go away within about a minute or two, and the amitriptyline is pretty necessary for these to work. Prior formulations where the amitriptyline was not involved, it was not in the regimen, people were having much more prolonged deaths for 6-8 hours. So, 1 to 2 minutes of burning with the amitriptyline really is worth it for the very good results we've gotten with this regimen otherwise. So just wanted to throw those things out there for explanation. Okay, next slide. Support. Someone else mentioned this. The support of an institution, of the hospice involved, of the family involved, the importance of that support to medical aid in dying going off without a hitch cannot be overstated. Having supportive family there, especially for someone with ALS who is going to have a lot of difficulty advocating for themselves, is just, it's incredibly important. So in most cases, of all aid in dying, but in ALS in particular, the family is generally very involved with daily caregiving. In my medical aid in dying appointments with ALS patients, usually they are all there and they're going to be doing a lot of the coordinating of their care. And so having them on board is very important. Hospice, the National Palliative Care Association has a stance of engaged neutrality when it comes to medical aid in dying. Most hospices, in my experience, are supportive, but that's going to be highly variable and dependent on your location in the country and your location within your state. And so if somebody is intending on pursuing medical aid in dying, I generally have them, or I will personally, if they have a list of hospices that they are considering, I might call on their behalf and ask them what their stance is on medical aid in dying. Do they have experience with it? Are they going to be supportive of a patient who chooses this? You know, what are their particular policies? Because they might have policies that are more restrictive than the actual laws in the state regarding medical aid in dying and what they're willing to do with the patient and what they're not. So making sure that the hospice that is chosen, because the family gets to choose which hospice is taking care of the patient, that they are going to support the patient through this. It's incredibly important. And hospices are usually there on the day of ingestion. They may even, depending on their policies, assist in preparing the medications for the patient, or at the very least, helping them say, you know, okay, it's time to take this one. This is the one that you take next, you know, and kind of helping them through that process. Some of them have policies where they will step out of the room when the patient is actually taking the medications, which I'll be honest, I have never understood the why that makes sense, but a lot of them do that. And then they'll come back in and they are there with the family and the patient through the whole transitioning process as the patient drifts off to sleep and as they transition and pass away. And it's also worth noting that the times where I have seen medical aid in dying not go great, it's the times where hospice was not involved. So having hospice there is super important for medical aid in dying to go the way that we all want it to go. It doesn't matter if the family member is a nurse or a doctor or whoever. That person needs to be the family and the support and not their medical caregiver in that moment. And that's really why hospice is there, because you're not going to be objective if you are the family member. Really, you should have hospice involved and present. And then also having members of the faith community involved may be important for different patients, and the ALS Foundation involved as well. They can lend support. It's not on this slide, but a lot of states also have volunteer programs where you can contact a volunteer who will personally come and be there through the medical aid in dying process, and they can be very supportive as well. So challenges, we kind of talked about this or briefly mentioned this before, but self-administration can become problematic as someone gets further through the process of ALS as they progress through ALS. And so planning ahead, plan ahead, plan ahead. If someone is starting to have difficulty swallowing or difficulty expressing themselves, but they want medical aid in dying, they've really got to seek it out, get their verbal requests done, get that waiting period started so that they don't miss their opportunity, because they do have to also maintain mental capacity through this whole process. And so what does that mean? That means that they have to be able to still express a decision, that they have intact judgment. And so in some cases of ALS, people can start to have cognitive impairment as a consequence of ALS. And so you really don't want to get trapped into that circumstance where somebody wanted it, but then they've kind of waited a little too long, and now they're starting to have cognitive decline, and they may not be a candidate anymore. It's also important to mention that it's written into many of these laws that somebody's judgment must not be impaired by a psychiatric illness, such as depression. It's important to note that many people who are dying are depressed, just naturally, as a natural consequence of the fact that they are dying. They will have grief about the fact that they are dying. That does not mean that they necessarily have uncontrolled major depressive disorder that is causing them to reach for this option. And that's really where the difference comes in. You can be dying and want this and not necessarily have depression that is causing that desire.
I'm going to jump in, and just because we're getting late, the time is flying and we have a lot of questions. So rather than give some case examples, I'm thinking that we should jump to one of the questions that came up was about other diseases such as Parkinson's disease, if they can use medical aid in dying.
Well, I'll take that question. Of course, anyone can use medical aid in dying if you live in an authorized state or jurisdiction like DC, and if you have a terminal illness, no matter what the diagnosis is, and if you have mental capacity. So any of the neurodegenerative diseases, Parkinson's, etc. Now, the caveat, of course, in Parkinson's is that there's a larger cohort in that subset who have loss of cognition versus ALS, where the vast majority, even to the end, are able to understand what they're doing. But if there is capacity, any disease aid in dying can be used for that.
I think a related question is about why the 6-month limit when people with neurodegenerative diseases might want to start this process sooner.
Yeah, and I can touch on that. So the laws aren't perfect, and there are safeguards that are in place, or things that are intended as safeguards that are sometimes barriers. And the 6 months is somewhat arbitrary, but it was chosen to line up with the Medicare hospice requirements of somebody having a diagnosis or a prognosis of 6 months or less. So the 6 months is really chosen to line up with the hospice requirement, which is a more generally accepted definition of someone being terminally ill. But it is correct to opine that does limit people who have a longer course ahead of them, but do have a poor quality of life already. But it's very difficult to tease that out and create a law that would be just and fair to everybody and not potentially have safeguards loosened. Would you agree with that, David?
Yes, I absolutely do agree with that. No law is perfect, and this is the law that we currently do have, and there are situations, but I think the bigger issue is that people come to this choice too late, as they do hospice. And many more times we find people who have 1 or 2 days left and they're having terrible suffering and they want aid in dying, and there's no way they can go through this whole process. That's a much bigger issue, is than the individuals who may have 12 months but are already in decline.
Another question came up from somebody in Northern Virginia where there is not a medical aid in dying law, but they do have one in DC. What's their ability to go to another jurisdiction? And then there was also a question about how long you have to be somewhere to establish residence.
The residency requirement is variable from state to state, so I'd have to look at the individual statutes to understand that. I don't think we could talk about all 11 jurisdictions. Yes, individuals can travel to another state. I think the most the most well-known case is Brittany Menard, who traveled from California to Oregon to access aid in dying before it was an option in California. But recall now, these people are very, very sick, particularly in ALS. They're generally paralyzed, they're bedfast. For them to travel to another state, to have to find 2 different doctors, to have the waiting period, to not be in their own home with their family or loved ones, is very, very problematic and generally doesn't work out. So it's not something that I recommend. And I've had quite a number of occasions to know stories that this does not turn out well.
And so a question that keeps popping up is, how do you determine the 6-month mark?
So that's, I'll take the start of this one. That's a very great question. And of course, as we've said, the laws are not perfect and the doctors are not perfect. There are templates that can predict prognoses that have been published and are available to most medical directors of hospices. But if you really look at the statistics, I refer you to Dr. Atul Gawande's book, Being Mortal, where he shows that there's a 6 times greater chance that we will predict a person lives longer than they actually do. And only 17% of the time does doctor actually predict a terminal diagnosis and they live longer. And the worst group to predict this are family physicians. And why is that? Well, it's because we love our patients and we don't want them to die and we don't want to predict that they will be dying. And so actually the statistics show that physicians do a very poor job of predicting 6-month prognosis in the opposite way that you might think.
So I'm going to do a quick, we are actually over time, and I think this just demonstrates that there's a hunger for more knowledge and understanding about how medical aid in dying works for someone with a muscle weakness. And so we might want to consider doing something like this again, but just to remind folks, this will be on our website. I wanted to show you that there are some resources for patients on the Compassion and Choices website. We have lots of end-of-life care planning tools, including a booklet about voluntary stopping eating and drinking. We also have a Find Care tool, which if you put your zip code in, you can help find a facility or medical team or hospice near you that does support medical aid in dying. And then we also have some resources for clinicians. We have a doc-to-doc program, which is a free confidential telephone consultation with an experienced clinician. So you can contact us either by phone or by email, and just check our website there. And then you will set up a time to talk with one of our professionals, either David Grube or another physician. And then the American Clinicians Academy on Medical Aid in Dying, I put their website here too. They do a lot of research, have information about clinical practice to set up best practices. They have some CME opportunities and do training, and also have a referral network. So lots of resources here. Again, you can see these on our website. If you miss any of this, you can just go back and take a look at the presentation. And finally, because all that we do these webinars for free, we really look for support from you out in the audience. Everybody who contributes to this organization does so as an individual donor. We have no government support. We have no interest group support. We just have support from individuals. So if you appreciated this and you haven't made a donation, whatever amount works for you, kind of like public radio, we'd love to have your support. So we're going to end it here. And I want to thank Dr. Spielvogel, Dr. Grube, and Lenore Keibel for your time. And if you did not get your questions answered, feel free to shoot them to me and I will get them to one of our doctors and try to get those questions answered for you. We had 75 questions, so I'm sorry we didn't get to them all. But thanks everybody, and we look forward to seeing you on, we have another webinar coming up next month. Check our website for all those details. Thank you.
And I want to just put a quick plug in that, you know, you go to the Compassion and Choices website. There's a lot of information there. Also, I mentioned the American Clinicians Academy of Medical Aid and Dying, acamade.org. There's a lot of information there as well. So I wanted to put a plug in for that as well.
Thank you.
Thanks, everybody.